So now with this chapter we try to put it all together and review what we have done and teach so far in this book into the practical approach. Now the first thing that you need to do is to review for this case the MRI scans that we have provided you with, and I would suggest that you go through the MRI scans according to the suggestions that we did make in the indication for surgery chapter. Please do so and then come back to this video. So what is your tentative diagnosis after reviewing the MRI scan? So our diagnosis was a low-grade glioma with potential anaplastic focus. Do you agree? So now comes a very important point. You need to analyze the MRI for structures at risk. And in principle there are two. There's a vascular risk and there's a risk of inadvertently damaging functional tissue. Now for the vascular risk, you need to analyze vascular involvement and think about protection of the vessels. So, for example, can you protect the vessels by choosing a subpile approach, using the pyre as a protective layer? Now, the second part is neurological damage. Now, here you can induce deficits by impairing cortical functions. And again, at this point, you need to review what kind of tests you could imply to analyze these functions and to test them intraoperatively. And the same goes, of course, also for the subcortical areas. Identify these structures and think about how to test and identify the structures in your planned surgery. Now, having done so, you will be able to conclude in summary what kind of monitoring you will need in this specific case. You have the option of wake asleep, 60 Hz or monopolar stimulation, transcranial MEPs, SSEPs, and the use of the grid. That's fairly the setup that you should have at your hands when you plan that kind of surgery. As you have now identified the intraoperative monitoring that you want to apply, you can give first and fairly accurate risk assessment, and therefore you will be able to define the extent of resection that you might be able to perform. Is it just a biopsy? Can you go for a lesionectomy? Can you even apply a supramarginal approach and use subpile resection techniques? At that point, it is also very important to check whether the planned testing, especially in the wake testing, is feasible in this particular patient. Is he really able to perform lung wedge tests? Is he able to do subcortical mapping procedures like the PPTT or picture naming? What you now have in your hands is a technical plan based on the MRI scan, the tentative diagnosis, and what you need to do now is a reality check. You have to go to the patient and explain the plan to the patient. And then you need to adjust your plan, your risk assessment, and your plan of extent of resection and potential neurological deficits to the individual situation of the patient. And that takes a lot of time. And doing this, you will automatically, and that is absolutely essential for the procedure to come, establish a trustful relation with the patient. So that was the overview of what we think is essential in planning the surgery. And now let's put it into practice. So let's start with analyzing the MRI for structures at risk, and let's start with vascular. And I believe that this is best done in the T1 weighted images with contrast enhancement. So as you go through the MRI scan T1 axial slides, you will identify not any particular important vessel which is directly correlated within the tumor, or with the tumor borders, maybe there is, if you do interhemispheric approach, some issues with the pericallosal artery, but we don't have any perforators here. So I think that we can conclude that this lesion doesn't have a particular vascular risk. So after assessing the vascular risk, we will now define the neuronal structures at risk. And starting with the cortical functions, we always have to have in mind how to test these cortical functions. And we will start with analyzing the cortical localization of the lesion in regard to eloquent structures. And to do this, we would take the MRI, and in this case I would suggest that we use the axial T2 because we have there the good definition of the sulci and the coronal flare for the division of the cortical involvement. So run through the MRIs of the T2 axial sections and analyze the lesion for its localization in relation to cortical structures, M1 motor cortex for example. Name the localization of the lesion regarding to the gyrus and define the relation of the lesion towards subcortical fiber tracts. Now the cortical involvement of the lesion is in this case best demonstrated in the coronal flare. Just go through the coronal flare, define the localization of the cortical involvement of the lesion, try to find the sulci which separate the lesion from the adjacent normal appearing brain, and get an idea about the potential involvement of, again, subcortical structures like fiber tracts, and try to identify the cortical spinal tract. So with a simple drawing I've outlined the localization of the lesion in comparison to the contralateral side, and you see that the localization of the tumor is within the superior frontal gyrus. Now the superior frontal gyrus is directly adjacent to the primary motor cortex, and what you can see in this axial slide as well is the hand notch, which is outlined here. And therefore we have now the definition of the pre-septal sulcus, the hand notch, and therefore identified the M1 motor cortex. So what does this mean for our surgical strategy, especially for our planning of the intraoperative monitoring? Now, directly posterior to the superior frontal gyrus on the left side, we have identified the primary motor cortex, a highly eloquent structure where, when we perform monopolar or bipolar stimulation, you will get clear muscle responses, and we will probably get no responses on the cortical surface of the superior frontal gyrus. Now, as we will see in the surgical video, and as we have already explained in the text, it is essentially for the performance of intraoperative monitoring to get a positive control and to define the threshold. And that's exactly what we can do on this motor cortex for bipolar stimulation and for monopolar stimulation. And therefore it's extremely important to expose this part of the neuronal structure. So let's wrap up a little bit at that point. So we have identified the primary motor cortex, and we have already discussed how to test the primary motor cortex, and we can do this with or 60 Hz stimulation by having just simple motor counting, motor testing of the language by counting. We can do differentiated movement testing by blocking with 60 Hz hand muscle, face muscles, and even the leg. Or we can do monopolar stimulation targeting the muscles that we have available in our EMG recording. Now let's switch to the subcortical localization of the lesion and analyze the MRI scan in this regard. And I would suggest that we here use again the flare coronal sections, and in addition the sagittal T1. So let's start with the extreme posterior part of the lesion, and what you can see here is that the extreme posterior part of the lesion, which I stained with yellow, is, if you compare it to the anatomical structure of the non-inflicted right side part, very near to the cortical spinal tract. Now, for the performance of surgery, it's extremely important to identify this problem, because it can either be that the infiltration zone is still separated from the cortical spinal tract, or, as you can see here, is involving the cortical spinal tract. So we have identified one of the key features of our surgery: posterior border infiltration of cortical spinal tract. So, subcortical localization, cortical spinal tract. Now the issue is how we will test that. And the options that we have for that is, again, like for cortical testing, using 60 Hz stimulation or the monopolar stimulation. But in this case, we will do monopolar stimulation with a subcortical setting. So let's proceed with our analysis of the subcortical structures. To this end, we will take the T1 sagittal. And what you can see is that I mark the tumor and I draw in a red lines which are corresponding to the inferior fronto-occipital fascicle. The yellow lines correspond to the superior longitudinal fascicle with parts of the arco artus. Now in this coronal section in the flare, you see the yellow structure, which is corresponding to the SLF1 and 2 and to the arco artus, and you see this green lines, and these lines correspond to the FAT, which is the frontal Arslan tract. So apart from the cortical spinal tract, we have identified further subcortical localizations of functions at risk, and these are corresponding to the IFOF, the SLF, and the FAT. Now, how to test these structures? Now, IFOF and SLF are usually tested by let the patient perform picture naming and PPTT, and the FAT is tested by sentence production. Now let's start planning the intraoperative neuromonitoring based on the results that we have gotten from an analysis so far. So we have the primary motor cortex, we have the cortical spinal tract, we have the IFOF, the SLF, and the FAT. So in summary, what we need for our monitoring would be awake with 60 Hz stimulation, monopolar stimulation. We would probably be happy to have transcranial MEPs. SSAPs is probably not necessary, but we will certainly use the grid electrodes. So now, based on this plan of intraoperative neuromonitoring, we can now define the next step. The next step would be the definition of the goal of the procedure, basically on the end point of surgery. Now, the limitations of the resection by the functional structures are given by the M1 motor cortex, the cortical spinal tract, the IFOF, the SLF, and the FAT. Now, what is possible in this case? Certainly not only a biopsy, but we probably could go all for lesionectomy. There are certain parts of the surgery where we can probably perform a supramarginal resection, and there are also aspects where we can perform a subpial resection. And to analyze this, we will go back to the slides, look through the MRI scans, and plan our surgical strategy corresponding to where we want to do the lesionectomy, where we want to do the supramarginal resection, is it possible at all, and where can we perform or plan at least subpial resection. So you remember this slide, which demonstrates the localization of the motor cortex, at least what we assume would be the motor cortex, and the relation towards the superior frontal gyrus, which is harboring the tumor. Now, in terms of motor mapping, we will have certainly a very highly eloquent and very functional area corresponding to M1, but probably have no motor response in the superior frontal gyrus. So that would be, in terms of motor testing on the cortical level, probably resectable. Now on this slide you see that I outlined the potential resectable part of the tumor, and you see that we have the possibility, if the testing is really negative, to perform a subpine resection towards the precentral sulcus, towards the lateral sulcus, which separates the superior frontal gyrus from the medial frontal gyrus, and of course we have a pile border towards the interhemispheric fissure. Now if we look at the coronal sections in the FLAIR, we can define, and that is the pinkish lines that are drawn, subpile resection areas, always limited towards the subcortical structures, and that is the reddish structure here corresponding to the IFO. So we will be able to perform subpile resection, but then we will have the limitation towards the functional areas of the IFO, which needs to be tested, and we just talked about how to test it. The dark area that I put in is principally the area where I could expect to perform a lesionectomy. Now if we go further to the posterior part of the tumors, you might encounter areas, and that is the bluish stuff, where we can get out of the part of the tumor which is visible in the MRI or in the ultrasound and perform a supramarginal resection, but then again we will have a limitation towards the part where we will encounter the functional areas corresponding to the SLF1, 2 and to the arcuatus. And at the end of the surgery, we will certainly enter a very and highly eloquent area where we will be limited by our resection due to the fact that there is the FAT here in green and the cortical spinal tract in red, and still the yellow structure of the SLF. Now, the analysis of the MRI scan has led us to several conclusions. Now, we have defined the primary motor cortex, the cortical spinal tract, the IFOF, the SLF and the FAT as limitations of our planned resection, and have developed a plan for parts of the tumor prone to lesionectomy, supramarginal, subpile resection. I think that depending on how the testing during surgery will be performed and what we will find during surgery, large parts of the tumors can be removed. That's a lesionectomy. We will have parts of the tumor where we can even go for a supramarginal resection, and due to the anatomy of this lesion, we can and we need to perform large parts of the resection as subpile resections.